This is Rory Stoughton. In 2012, Rory was playing basketball in his school's gym when he slipped, got a cut on his elbow, and the teacher dressed the wound. During the night, Rory awoke with great pain in his body. He had a high fever and was vomiting throughout the night. He visited his pediatrician the next day, who thought Rory contracted a viral infection, something like the stomach flu. She instructed Rory's parents to take him to the emergency room to treat his dehydration from all the vomiting he did the night before. Rory got to the emergency room. His doctors ordered an entire panel of blood work, but no doctors or nurses ever followed up on those results. The emergency room doctors passively agreed with the earlier diagnosis of Rory's pediatrician that he must have had a stomach virus and sent him home after treating his dehydration. At home the next day, Rory spiked a high fever that his parents just simply could not control. They went back to the emergency room and Rory was immediately admitted to the ICU, or intensive care unit. He was fighting a serious blood infection and was in grave shape. Bacteria had entered through the small scrape in his arm and he was in septic shock. Despite Rory's fight to survive the infection, he passed within 48 hours of being admitted into the ICU. Rory's death is a case example of an adverse medical event that could have been prevented if not for a breakdown in interpersonal communication. Rory's pediatrician, his primary care physician, could have listened to his parents better when describing his symptoms and come to the correct medical diagnosis. His pediatrician could have also communicated better to the team of doctors and nurses who treated him in the emergency room. And his team of doctors and nurses could have communicated with each other better to ensure that the results of his blood work did not show anything counter to their suspicions of a stomach virus. If any chain of miscommunication in this cycle were connected, Rory still might be alive today. In the traditional model of medical care, one primary care physician provides overall medical care and consults with other medical professionals in their areas of expertise as it relates to the illness at hand. Examples of specialists are orthopedists if the trauma or disease relates to joints or bones, oncologists if the disease relates to cancer cells, cardiologists if the disease or trauma relates to the heart, and neurologists if the disease or illness relates to the brain. The way primary care physicians communicate their initial evaluation to other specialists is through the use of detailed notes in the patient's chart. The quality and comprehensiveness of these notes, a form of interpersonal communication, is analogous to the care received by the group of doctors. In the 21st century, the traditional model transitioned into a team-based model of medical care, especially for inpatient care. In this approach, a team of medical professionals, each with their own specialized forms of medical knowledge, participate in small group communication rather than dyadic or one-on-one forms of communication taking place in the traditional model. Team-based care is a model of medical care where key players, including doctors, nurses, physician assistants, specialists, and other non-clinical professionals, communicate and cooperate with each other to drive medical care. Effective teamwork, a clear common goal with well-articulated targets, and supportive organizational frameworks are all signs of successful team-based care. When team-based care is successful, patients report better experiences and feeling safer and more confident in their medical care. They also feel like they're receiving a high quality of healthcare when their healthcare professionals work together. Team-based care can also lead to quicker recovery from the illness, which reduces burden on the healthcare system. Finally, healthcare professionals report feeling less burnout when working in a team of healthcare professionals. The importance of medical communication can be illustrated in the following scenario. Imagine you're driving down a one-lane road when you suddenly get into a head-on collision with another vehicle. You know you've sustained a serious injury to your leg, but you don't exactly know what that injury might be. It's likely that the first responders will call an ambulance with paramedics or emergency medical technicians to triage the scene. The emergency medical technicians or paramedics will do an initial assessment and then provide you with preliminary care. In some instances, paramedics can do life-saving procedures like using defibrillators, administering medications, and performing tracheotomies. The ambulance will likely transport you to the nearest hospital with an emergency room. There, the paramedics will leave you in the care of a group of ER doctors and nurses who will further assess your injuries and treat you for any urgent issues. After, it's likely, given your serious leg injury, that the emergency room doctor will consult with radiologists, surgeons, and other medical professionals to provide you with additional care. In each string or segment of medical care with which you are provided, a patient handoff occurred. The patient handoff is a term used in medicine whereby healthcare professionals transfer medical information about you, including possible diagnoses, medications, and treatments, to other medical professionals for continuity of your healthcare. So, for instance, the ER doctor might conduct your handoff to a surgeon, an orthopedist, and/or a radiologist to continue your more specific care to your leg injury. The cornerstone of the patient handoff is the transfer of responsibilities between or among participants. Consequently, handoffs require transactive communication involving active involvement between or among the healthcare professionals. Several benefits can be observed when patient handoffs are conducted with fidelity. For example, a well-conducted patient handoff could promote patient safety, it could maintain a strong continuity of care, and it could enhance perceptions of professionalism and teamwork. Likewise, when medical professionals mishandle the patient handoff, you can observe medical communication failures. These failures result in omissions of health care tasks for the patients, misunderstandings as it relates to the threshold goals and overall healthcare plan, and adverse medical errors like the ones we observed in the introduction with Rory Stoughton. And that's essentially the point of scrutinizing interpersonal interactions in medical communication, to avoid these adverse medical errors. Adverse medical errors are any injuries to the patient caused by medical mismanagement rather than the underlying illness for which the patient sought medical help. The negative effects of this harm can be life-threatening illness, disability at the time of discharge, or prolonged time spent in inpatient care. There are two broad categories of adverse medical errors: errors of omission and errors of commission. Errors of omission occur as a result of actions healthcare providers did not take to provide care to their patients. Examples might be failing to provide a necessary drug like epinephrine when a patient goes into cardiac arrest, or failing to follow up on an important toxicology report. Errors of commission, in contrast, occur as a result of wrong actions taken. Examples might include administering a patient medication who has a known allergy to it, or giving an incorrect dosage of a drug to a patient. Because the main mandate of clinicians is to first do no harm, healthcare professionals who commit these types of adverse medical errors, usually on account of a failure of interpersonal communication, feel profound psychological effects such as anger, guilt, depression, or even suicidal ideation. That's pretty much all I have for this second module on medical communication. In this module, you learned about traditional and contemporary team-based models of medical care. We reviewed the importance of the patient handoff when receiving different forms of care from different providers and professionals. Finally, you learned about adverse medical errors among clinicians and ways to avoid these errors. As usual, if you have any questions, please drop them in the comments of this video or feel free to email me. Thank you for watching until the end, and I'll see you again next week.